She really taught me how to live and how to love in a way that I didn't really know before. We had a whole weekend planned of activities and making our way back towards the marina, and something went terribly wrong. There was a huge crash and everything went blank. Jennifer was thrown forward and crashed through the cabin door down to the lower galley, and I spent the night in the hospital myself, so I was unaware of what was really going on until the next day. That's when I learned she had a lot of continued complications with her breathing. We had gotten Jennifer to the place where she was now able to speak. She was able to write. And she wrote in big letters that we're gonna make it. And at that point, I had every reason to believe that that was true. We were so excited because Monday morning she was scheduled for a barium swallow test. And that was the last big hurdle. With a green light on a barium swallow test, she was going to go home. I since have become very familiar with a term called TEF, which is a tracheoesophageal fistula, which is basically a hole that establishes itself between the trach and the esophagus. The barium went down her esophagus and then was quickly seen to migrate into her trach and then quickly spread into her lungs. They were blowing her full of air for 6 hours. Instead of it going into her lungs, it went into her belly. They told me that Jennifer was in cardiac arrest for over 14 minutes. She was so oxygen deprived that everything just shut. How is it possible that on Monday morning you have a definitive diagnosis of a TEF, but Tuesday afternoon she's back on a positive pressure ventilator with no isolation and no protection from that hole that they had just discovered? I've since learned a lot about electronic medical records and something that the industry talks about, which is the problem list. Problem list is a idea where you take all of this aggregate information and the computer systems try to organize it. The most problematic condition is sort of forced rank to the top, and then everything sort of in descending order follows thereafter. It's tricky, but it's where electronic medical records have to go, because no human can possibly absorb as they're coming onto a shift or as they're assigned a respiratory case like Jennifer's. I have 4,661 pages of her medical record. One page, one paragraph, talks about the TEF. So what did the caregivers know at the most critical time? I don't know. They clearly didn't know she had a TEF. We all go into those environments with a false sense of safety. The truth is, there's so many moving parts. There's so much information. It's not well organized, it's not well communicated, it's not well coordinated. I don't believe for a minute that Jennifer's caregivers were intending to do any harm to her. It's just a case of they didn't know.
Hello, and welcome to this panel for the for our current summit, healthcare safety during the pandemic. What innovations should be made? My name is Mike Durkin, and I've the privilege not just to chair this session, but also to be the current chair of the Patient Safety Movement Foundation, which has had many summits over the years, but none more so important than our current one as we emerge from the last 2 to 3 years of ongoing issues with not just learning how to deal in real time with the pandemic, but also the impact that pandemic has had on many of the innovations that have been brought in over the last decade or so. We have a fantastic and distinguished panel here to discuss those elements that reflect not just at a hospital and a university level, but also we're privileged to also have international leaders, national leaders from the US, and also from our global leaders for WHO. I'm going to let them introduce themselves shortly, but I first want to ask us just to reflect on the video that we've just listened to, that story that Brent told so eloquently, but also so poignantly about his wife, Jennifer, who was surviving after a boating accident. And then as she was recovering and they felt that they were on their way forward, there was a breakdown in communications, a breakdown in the handover approach that was taken at the hospital that she was in, and she suffered what would be seen as a very preventable error. So we need to reflect on Jennifer, reflect on the ability for Brent to talk about that story so effectively, but also to be mindful, I think, about his positiveness about learning from that error, and the responsibility for all of us to learn constantly of how we can improve not just the lives of our patients, but also the lives of our fellow healthcare workers who work across many different systems and settings, and none more so than over the last two years or so. So what I'd like to do now is to move us on, and I'm going to introduce each of our panel members, but I'm going to ask them to tell us who they are, and then what is it about the last 2 years or so that has made an impact on them with regard to their own elements of safety and their leadership of various elements. So I'm first going to ask Lee Fleischer to introduce himself and also give us a reflection of 3 or 4 minutes on what he's found over the last 2 years. Thank you, Lee.
Thanks so much, Mike, and it's a pleasure to be here. An honor. I was here in a previous meeting, but as the chair of anesthesia at the University of Pennsylvania, but now my role since July 6, 2020 has been as the CMS Chief Medical Officer and the Director of the Center for Clinical Standard and Quality. And for those who don't know, the Centers for Medicare and Medicaid Services, we're the largest payer in the United States, responsible for the quality of care for 147 million Americans, and we oversee the facilities that take money from the federal government. So there's really a two-part story, and being a fellow anesthesiologist, as several of us on this call are, it was being the chair of anesthesia when I came home from a national meeting and stood up the intubation teams for COVID response back in March of 2020, and watching the fear, the anxiety of providing care when you don't know, how safe you will be, as well as the issue of bringing it home to your family, which was another great fear about the virus during that time, and sort of having to institutionalize things that really through checklists, but more importantly through culture, we knew how to do, but all of a sudden we had to put PAPRs on, and we had to put N95s, which we rarely do. So, retraining, having second people watch you so that there's really almost a buddy system. But interestingly, we worked with an organizational psychologist at the Wharton School and surveyed my department and found some of the things that helped them over their anxiety, like being transparent about PPE, having clear guidance, giving them sort of hope as they were doing things they had never done before. Not only that, and I'm sure Mike remembers this, of anesthesiologists who hadn't done critical care in decades being called on to be intensivists in that SCCM model. And then I transitioned to this role, working almost on, I think at the beginning, it was 4 days a week with Arjun and the CDC, and trying to figure out why, in particular, the nursing homes, but we also were worried about the hospitals, and that's why we created Hospital Without Wall. What are the guidances, which were at times conflicting or delayed, as we know, but also why wasn't it working? And I think one of the key things that we both saw, because we sent out teams to actually do observations, was the issue of implementation in the real world under extreme stress. That there were plans on the shelf, but they really didn't know how to do it, implement best practices under those extreme conditions. And that led to our editorial, and we can talk about that later. But I think the key thing is that we need to practice, because whether it's another public health emergency, a weather emergency, a generator shutdown, which happened when I was back at Hopkins, how do we think about dealing not only in times of where it's not stressful, but in times when we have no choice but to go forward and take care of patients as well as ourselves in times of stress. And I'll stop there.
Great, thank you, Lee. Thank you very much. So you've already set up a lot of trains of thought for us, I think, to have our conversation later in our session today. I'd now like to turn to another good friend, Dr. Neelam Dhingra Kumar, who leads the flagship of patient safety at the World Health Organization in Geneva. But Neelam is known around the world for her tireless work in leading not just individual elements of safety, but trying to bring a coordinating impact globally through many different elements. But one in particular, I think, which will stand the test of time is the Global Patient Safety Action Plan, which she has brought to us, and it outlines the beginning of a decade of work on patient safety. So thank you for that, Neelam. But over to you now to introduce yourself and your reflections from a global perspective. Thank you.
Thank you very much, Mike. And thanks for the kind introduction. My name is Neelam Dhingra. As Mike mentioned, I'm heading the patient safety flagship at the WHO headquarters in Geneva. And the department in which I sit is actually part of Universal Health Coverage and Life Course department. So our focus has been looking at patient safety from health system perspective. And I'm going to share with you how patient safety sits at the center of health service delivery and health system strengthening. We all recognize that patient safety is absolutely foundational to healthcare delivery and essential for progress for universal health coverage, which is the global initiative as part of SDGs. We all recognize that no one should be harmed in healthcare. However, as per global estimates, patient harm due to adverse events and unsafe care is likely to be one of the leading causes of death and disability worldwide. While patients were already at significant risk of harm in healthcare before the COVID-19 pandemic, lessons from the pandemic emphasize the need for better, prepare for safer and more resilient health systems. The risks and avoidable harm from the pandemic have been very prevalent, and many of the risks and harm have been common across countries. I must say that the pandemic has profoundly impacted the country's health system, as well as further diminished its capacity to provide safe healthcare, specifically due to errors, harm, and delays in diagnosis, treatment, and care management. It also revealed a range of safety gaps across all core components of health systems at all levels in all settings. Some of these safety gaps are in relation to health service provision, leadership governance and financing, communication and management of health information. We all know the misinformation and disinformation and the safety risks associated with it. And then also development of medical products, vaccines, and technologies, which happened during the pandemic, and also their supply chain issues. Issues related to health and safety of health workers, and also engagement of patients and families and communities, and even inequities were all very prominent. And we all recognize that all these issues have major safety, risk, and harm implications. Provision of care in highly pressurized situation and in suboptimal working conditions, we all realize has many inherent safety risks. And some of these risks of avoidable harm during the pandemic were applicable to patients, health workers, and also to general public. And I must say that there was increased recognition of these risks and important patient safety implications that emerged, such as increased risk of healthcare-associated infections, increased risk of medication errors, new types of diagnostic errors, particularly with the new virus, and then the physical and psychological safety of health workers, and delay in treatment of several serious conditions. And these delays, we know, arose from patients not seeking care due to fear. Patients were unable to go to health facilities due to lockdowns, and those with complex chronic conditions, they could not receive their routine care or preventive care due to health system overload. So this basically the healthcare systems across the world have been overwhelmed and stretched beyond limits, and under extreme pressure under which healthcare workers have performed, but they work tirelessly in these situations. And staffing shortages, staff redeployment to unfamiliar roles, and workarounds all disrupted existing care processes in most of the healthcare systems worldwide. And I must say that the high patient load in endemic situations made health workers very prone to making errors due to long working hours, fatigue, burnout, psychological distress, and lack of communication and even care coordination among health workers. So to summarize, I would say that COVID-19 pandemic has exacerbated the safety challenges that healthcare system workers, patients, and leaders face today. And there's actually an urgent need to make healthcare systems more resilient to the impact of harm, more than ever before. And also there's an urgent need to promote the spread of safety strategies and innovations, which actually came around during this time. So I must say that it's time for us to build safer healthcare systems that minimize harm to patients and healthcare workers and provide safer working environments. And pandemic has demonstrated that there are several gaps in service provision and safety of healthcare systems worldwide. Over to you. Thank you so much, Mike.
Great, thank you very much, Neil. I mean, you've set out a broad range of elements for us, and I think it chimes very well with Lee's points about implementation when under stress, the absolute requirement to have a resilient systems, and it's the systems I think that we've now discovering have, if they haven't failed, they haven't been sufficiently robust across many of our countries and nations around the world. The world looks to the CDC. It's interesting that there's a great privilege to have Arjun with us today, because the world looks to CDC as a fount of huge resource for us. And there's no doubt that we've learned over the last two and a half years now of the absolute importance of the collection of data and the use of data, but also the information that data can provide. Arjun, thank you for joining us today. And now I'd like you to introduce yourself and your reflections, which I know that many will want to listen to. Thank you.
Thanks so much, Mike. My name is Arjun Srinivasan. I am a captain in the United States Public Health Service, and I work in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention here in Atlanta. And as our name implies, our mission is to protect patients and healthcare workers to provide the safest care that is possible throughout any place that healthcare is delivered. Our focus is domestic, but we also have an international team that works to bring that same mission globally. A lot of our focus has historically been and continues to be on healthcare-associated infections and antibiotic resistance and antibiotic use, because we know those are our core areas of harms to patients. And I think when I reflect on the last 2 years, and I think this has come out a little bit in what both Lee and Neelam have said, we think about this kind of double threat, the dual threat that COVID has posed to healthcare delivery. So what we see, especially in the United States in our nursing home settings, is the threat of COVID itself, right? The explosive transmission that we see within these long-term care facilities, nursing homes, so many people getting sick, a very, very vulnerable population, tremendously high rates of mortality. So these are patients who are suffering because we were not able to prevent the spread of COVID within many of our nursing homes. Our infection control infrastructure was not sufficient to prevent the spread of COVID. And that's the threat from the disease itself. But then move into the acute care setting, and what you see is not only the threat of the disease itself, people getting sick from COVID, needing, as Lee said, intubation, prolonged ventilation, critical care, life support, but that's compounded by the harms that happen while that care is being delivered. And it's so reminiscent of the video that we just heard. I've talked to so many healthcare workers who are saddened, even devastated, because they saved a patient from COVID. They took a patient who was literally at death's door from COVID, and through incredible effort, Herculean effort, they saved that patient's life. They saved them from COVID, and then the patient died of a central line associated bloodstream infection or a methicillin-resistant Staph aureus infection. So devastating impact for those healthcare workers who worked so hard, who thought they had gotten this patient back from the brink, only to have that person succumb to a harm that happened while they were in the hospital, right? That is the outcome that we are all together seeking to avoid in the future. And I think, as has been pointed out, we have to figure out how to build these systems better so that even under stress, we're able to keep people safe. In nursing homes, even when there is an outbreak, we should be able to prevent the spread of that disease. In the hospital, even when there is a pandemic, we should be able to provide safe care. If we can't provide safe care, then, like we said, what's the point? It's not a victory to save someone from COVID to lose them to a healthcare harm, right? All of this has to happen together. It's exceptionally difficult. I would argue that we don't really know how to do it right now, but the call to action, as we outlined in the editorial that Lee mentioned, the call to all of us is to work together to figure this out, because we have got to, for the health of our patients, who will be us someday, if not today, we have to figure out how to do all of this simultaneously. Let me stop there and Mike, turn it back over to you.
Okay, thank you, Arjun. Thank you very much. And again, we'll come back to that editorial, because I think it would be really good to see from both of you what reflections you have had since the publication of that. So now we'll move to Mike Ramsey. Mike is well known to everyone who is part of the Patient Safety Movement Foundation and has been an ever-present for us over many years. But he's also a researcher, a chair of a large university department. So Mike, thank you for joining us today. And I also want to also remind ourselves that you're also the chief executive now of the Patient Safety Movement Foundation. So you're taking this journey personally about trying to improve our safety and our resilient systems in many different settings. But can you outline your thoughts over the last 2 years or so? Thank you, Mike.
Sure. First of all, I became CEO of the Patient Safety Movement Foundation 1st of January this year. And that's after I retired as being chair of a big anesthesia department in Dallas. But safety is our focus. The Patient Safety Movement Foundation is a not-for-profit 501c organization. We started in the United States 10 years ago. It's now global. The goal was to get 0 preventable deaths to our patients. It's now moved to 0 preventable harm and deaths to patients and healthcare workers, because this was brought on us by the COVID and the number of healthcare workers who got hurt and their families from COVID. And it's gone global because this problem is not unique to us, it's unique to the globe, the world. Before that, I was the anesthesiologist chair and COVID hit us. And in the 40 years of doing anesthesia, I've never seen anything like it. I mean, we've come through lots of different infections that come through hospitals, H1N1 flu, but not the hundreds of patients that came in with COVID. We had to convert floors into ICUs. We had to convert operating rooms from positive pressure to negative pressure. What that means is now you have to seal that operating room because we don't want the virus to get out and get into corridors and hurt somebody else in the hospital. We had all to wear, as you heard Lee say, these N95 masks. Well, we didn't have that many, not for taking care of hundreds of patients. So we ended up having to be innovative, and we were cleaning these, sterilizing these. We had ORs full of masks hanging in them where we had been sterilizing them and reusing them. And the supply chain just wasn't up to it. And then the community came in, and this really, really heartened me. We had a big construction company in Dallas arrive in my office with boxes of 5,000 N95 masks that their construction workers were using, gave them to us. We had school kids who made face shields for us. They made them in school, in class in school, and came in with as many as we needed of face shields. And the Texas Baptist men came in with goggles for us to protect our eyes. So suddenly we had the protection that we needed. We didn't need all the protection we thought we needed. These were the basic things. And none of my department got COVID from a patient, which I'm very pleased to say. But we learned a lot. We learned a lot about resilience and the staff that stayed at work, came to work, worked in different areas. You can see why errors did occur because you're working long hours, you're working in ICU and you hadn't been there in years because we converted so many beds to ICU beds. We've got patients on what we call ECMO, extracorporeal membrane oxygenators, because their lungs are hurt. And we even had an ICU nurse who developed COVID, got on ECMO for a month in her own ICU on this extracorporeal membrane oxygenator, where the mortality rate is very high. Her lungs recovered, she went home, and God bless her, she came back to work in the ICU again. I think, you know, the resilience of people, the passion to get over this epidemic, take care of patients is heartening. And I know we're going to hear about how some of the preventable errors, we lost the advances we'd made because of the stress of COVID, but we're going to get back there. We're absolutely going to get back there. We're going to make our hospitals safer for our patients and our healthcare workers. So thank you, Mike.
Great, thanks, Mike. Now, anyone who's heard me chair these sort of sessions before know I got lots of easy questions to ask our panelists, but I also got some sticky ones as well. But what I really want to know is to find out about you personally, about the personal journeys you've been on during this last 2 years, because you've all led systems, but you're all now doing things that have reflected that you're working out of your comfort zone. And Lee mentioned it as well as Neelam about, but Lee mentioned implementation when under stress. And I think what we've learned over the last 2 years is that this has become the norm. And so how do we build systems to protect our patients and our healthcare workers like this? I'd like to sort of ask Lee to sort of come in on that one, not just in your new role, but in the thoughts that you put down in your editorial as well, you and Arjun. So just reflecting on those thoughts, if you could remind us of some of those elements, but also what do you think has changed over even in the last 6 months?
Yeah, no, and thank you for that question. And we did see, and this was a lot of the work of Arjun coming and Denise Cardo, the other co-author, talking with Michelle Schreiber and I, that we were seeing increase in infection rates. All the gains had actually of hospital-acquired infections had actually regressed. We saw it in our quality metrics, which we're constantly reviewing. Falls were increasing. So a lot of the things that Neelam spoke about. And it really, it's almost irrelevant because there's a lot of reasons we could have seen it. It could be that these are COVID patients. So it could be that these are non-COVID patients, but the question becomes, how quickly will we rebound? One of the questions that, Arjun and I, we want to still look at the data, but the fact that it happened so quickly, and the question is, will it rebound equally? And then what, was mentioned by Neelam in particular is the equity issue. And, the hospitals that could really are going to rebound fast and could implement fast is great, but we have a group of individuals who really will be left behind after this public health emergency, after the pandemic. And one of the things we saw is one of the differences in mortality, at least some of the research has shown, is the hospitals or facilities that cared for them were different. And that if you went to a place like Michael works at, like I still work at, like Arjun, I know we're all, many of us are still practicing. So the real question I have is, how do we lean in to the places that don't have the resources, that don't have that cultural infrastructure, that don't have the people I'm very fortunate. One of my trainees, Megan Lane Fall, is very involved in the anesthesia patient safety movement. It's really thought about these cultural issues. How do we help them? So I think one of the key things that I've been thinking a lot about, and I oversee the quality improvement programs, the QIOs, is how do we make sure that it's not just about guidance anymore? And Arjun and I talk about this quite frequently. We had all the guidances out. We had the CDC helping us draft guidances that were actually CDC, and then CMS adopted them. That wasn't the hard part, but how do we find out, use the data to find out where you need help? That's what I think a lot about. Stratified by the population you're looking at. So is the African-American population, is it access? Is it structural racism? Is it language barriers? I mean, one of the greatest things I heard about is a small hospital, a critical access hospital in the United States. So it's a rural hospital. We're prepared for the fact that they had a foreign language speaking community and they knew how to take care of them during the pandemic. I will tell you, I'm not sure our large facilities would have done the same. So it's really, I think, importantly, I've been thinking, how do we use the data to then give them the assistance to build those systems that are not just checklists and know how to continuously use their own data, but also the other thing is, how do they connect? I think one of the things we talk a lot about, and Arjun and I think a lot about, and I know, is in emergency preparedness, in safety, how do we use the places that have the resources to teach those who don't? And how can we teach them in a way they can learn? CDC, and I'll stop there. And Arjun, what's the name of the new hand washing Fire First?
Project First Line, the training.
Oh yeah.
Yeah.
And they showed us this phenomenal video that anybody can learn from. I mean, that to me was the future, is the innovation in Project First Line.
Okay. So Arjun, this is a great opportunity for you to press the button
Yeah.
on our,
So couldn't agree more. Project First Line is, a first ever attempt to try to bring that infection control training to every healthcare worker, 6 million plus healthcare workers in the United States. And we had this recognition that in the pandemic, one of our problems was people were not really well trained in infection control. And so what that meant is that we had to do all of this training to get people up to speed, to remind them how to use the N95 mask that maybe they hadn't used in many years, to remind them about putting on gowns and gloves and how to, more importantly, take them off without contaminating themselves. And the thought was, if we could have that training available so that people could access it and then refresh on it year after year, we wouldn't be behind the next time we have a pandemic. And I think that's where we were, right? We were behind and we had to get people up to speed. If you don't lose that first couple of months with getting people up to speed, you're that much further along the road and able to provide care. And if you start behind, you will always be behind. If you start ahead, you will always be ahead. And so Project First Line is an effort to do that. And the other thing I think we realized during the pandemic, and it builds on one of the points that Lee has made, is we talk a lot about the importance of health equity. It's so fundamentally important, but we really think about that as patient inequities, right? What are the patient factors that create poor outcomes for a patient? We also have to think about that at the facility level, because we know that there are facility level inequities. Even before the pandemic, we knew that there were nursing homes that had worse outcomes than the national average. There were hospitals, for example, 10% of the hospitals, even before the pandemic, had central line associated bloodstream infection rates that were significantly higher than the national average. So they were already behind, right? There were structural inequities. If you went to one of these facilities, your risk of being harmed was higher than at another facility. That's an unacceptable outcome, right? You should get the same safe care everywhere you go. And I think one of the things that we need to work on coming out of the pandemic is to heighten the awareness of facility level structural inequities and try to figure out what is underlying those and how do we get all facilities to that same level of safety.
Thank you, Arjun. Thank you. So when you were talking certainly about infection prevention control, hand washing, the techniques, I'm reminded of two or three things come to mind. One of them is how we do still seem to work in silos. We still seem to work in patterns which we know have been adopted and different in different countries. I mean, we've always talk about the biggest issue in safety is that we don't learn from each other, and also we stick to this hierarchical approach of the older man. Usually, the older man knows best, and we have to follow that line. And I'm just thinking, as you were talking then, Arjun, that what Neelam would be thinking about some of the global WHO programs, particularly on infection prevention control, hand washing, and where would someone like Didier Paté be at the moment? Who has led a lot of the work in terms of hand washing, and he's been at the Patient Safety Movement Foundation summits in the past. So I'm just thinking that in my head is he'll be thinking, well, why is it still not happening? Why are we still slow on doing this? Neelam, any reflections on this? Because I think it's fantastic to see great opportunities taken up and great new initiatives and support for new initiatives. But also, how do we reach those parts that haven't been reached? How do we get to support those systems that are, for whatever reason, slow to pick up change and slow to help their healthcare workers change as well? What's your reflections on that? Because you also have done a lot of work in terms of isolation and stigmatization of issues over the last 2 years.
Thank you, Mike. So I would just like to build on a couple of points which we mentioned and Arjun mentioned. First of all, we all recognize that patient safety is a very young discipline. And even now, patient safety initiatives are seen as add-on, not the routine work. The first mantra for quality is do it right the first time. But somehow patient safety initiatives are seen that something is done and then you add patient safety to it. And that's where, because it's a new discipline and we have a long way to go. So I would say that during the pandemic time, we actually have significantly lost on gains, even if they were uncoordinated in developing countries. There were major challenges related to safety and increased risk of harm, as well as harm actually occurred. So pandemic actually has been one of the biggest crises in patient safety ever. And so for me, the most important, I would say, loss has been focused on implementation. We had huge gains, Mike and colleagues, you would agree that from 2016, we had the Ministerial Summit series. At the global level, that really provided a huge momentum for patient safety. And we had 4 successful summits led by UK, Germany, Japan, and Saudi Arabia. And we had a resolution which was adopted by the World Health Assembly, major successes. All the governments around the world came together, political leaders, policymakers, international experts were fully engaged. And then we also launched the Global Patient Safety Challenge on medication without harm. But when it came to implementation of the resolution and the challenge, 2020 was really, where all the resources were reprioritized, whether it was financial resources or human resources. There was a major constraint on resources, and patient safety initiatives were seen as something which had to be done when it's possible to implement it. It's an add-on. It's not the way you do the things. So most of the government efforts were targeting to address the acute and urgent needs for healthcare in responding to the pandemic, and implementation of the resolutions could not be prioritized. However, every challenge has an opportunity, and I must say that 2020 and 21 also provided several opportunities. The World Patient Safety Day of 2020 was identified as to focus on the health worker safety issues, because health worker safety and patient safety are two sides of a coin. They are very closely interrelated. So the theme of health worker safety, a priority for patient safety, resonated across the world. And we also recognize how public around the world and families around the world utilize the opportunity while seeing the tireless work which health workers were doing across the world, to recognize by sort of making gestures of all sort of with clappings and ceremonies where health workers were recognized and their work was sort of acknowledged. So health worker safety really became mainstream, I would say, which actually was one of the sort of opportunity which the pandemic created. And the World Patient Safety Day 2020 really provided the highlights of it, and as a torch bearer to really prioritize health worker safety as a prerequisite for patient safety. Similarly, in 21, we had a theme on safe maternal and newborn care, and there were several challenges of disruption of essential care to maternal and newborn care, and these platforms through the World Patient Safety Day provided an opportunity again to focus on these issues. So I would say that 2 years of 2020-21, while they had major challenges and we lost on implementation and we lost on the gains of previous years, we had opportunities. And the Global Patient Safety Action Plan, as you mentioned, Mike, was one of the major landmark which we achieved in this period, which brought together global stakeholders, several consultations. Virtual world became the norm, and through that we were able to present the Global Patient Safety Action Plan as a roadmap for 10 years to the World Health Assembly, which was adopted by the World Health Assembly. So I must say that going forward, what in the last 6 months I've seen, as you asked, I've seen that patient safety is now considered very central to the efforts for recovery and also preparedness and response for future pandemics. So it is something which has to be hardwired in future strategic directions, whether they are pandemic treaty or high-level decisions. We have to advocate for patient safety elements to be incorporated. And that's an opportunity it has provided. I think in the last 6 months, it has been recognized. So several challenges, very slow implementation, but several opportunities as well. And I think the focus is going to be on implementation and action on patient safety. Over to you.
Neil. Thank you, Neil. Thank you. So I can feel my erstwhile colleagues on the front line saying, well, you all sit in ivory towers. You haven't got no connection to what's going on the front line. And I can see Lee and Arjun, who are still working on the front line. I can see Mike They're sort of stressing and straining a bit. But there is no doubt that we do have to create this link between the ivory tower, the font of knowledge, and the implementation phase at the front line. Because unless we're doing something that helps that conversation between our patients and their nurses and doctors, then we are wasting our time. So we've got to do that. Now, Mike, I'd like to come to you, Mike. So, you know, leading a difficult system, stress system on the front line. What are your reflections on this? Then, what would you have done differently, or what have you learned, and what would you have done differently?
I think it was all a learning experience, and I think we've learned from it. Would I have done it differently at the time? Probably not. I think we just learned as we went ahead. But I just want to reflect, and we got down to our last few minutes. Yeah. You talked about the ivory tower. I think that's where we've got to start. We've got to have the culture of safety in our hospitals, and it comes from the top down, and they have got to drive it. Secondly, we've got to have transparency in our hospitals. I know when the last wound infection was. I know when the last central line infection was. And I know what the blood sugar was of that patient. I know what the temperature was of that patient intraoperatively, but so does my department. And so do the people who took care of the patient. And it's not just one hospital, it's now a system. I know across the system, 51 hospitals, what the complication rates are. And so with transparency, suddenly it becomes real. And we know we've got to stop that. Did we do everything correct? And it's just one of those things we haven't yet figured out how to stop, or did somebody cut a corner? And we get checklists in place now. They're all on the electronic record, and we can see were things done correctly or not. And then just lastly, a point, I think one of the things COVID did teach me is that when we kept families out of the hospital because we didn't want them bringing COVID in or getting COVID, we lost a really potent safety factor. The patient's advocate was not there to ask the right questions, because when you're in hospital, you are stressed and you don't think to ask the right question. What drug is that? You know, did you wash your hands, doc? Well, I don't want to upset him. Well, the patient advocate can sure do that.
Absolutely, absolutely, Mike. Thank you. Yeah.
Okay.
Thank you. No, that's absolutely important, reminding us of that. Now, we do have our last few minutes now. So this 45 minutes has flown by. So so thank you for the participants for the panel members. But I got to give you one more chance. One more chance to say just a final message about what you've learned, but what have we learned in terms of that spreading of learning between, not just between hospitals, between wards, between systems, but what have we learned across the world on this? So I'll start with Lee, because I know that you may have to leave us earlier, but Lee, what's your message for us?
I'm going to actually pivot a little bit because we've learned a lot. We've learned a lot about implementation, but I just finished our quality conference. I interviewed Angela Duckworth, who wrote the book Grit. And healthcare workers want to do the right thing. They don't want to have errors. They want to deliver safe care. They are the grittiest people I have ever met. And when I go back to work, but she talks about 4 things. 1 is interest, and they clearly have interest. 2 is practice. That takes time. And getting back to Mike, your comment, the leadership needs to give people the time to do the things that they need to do to take care of patients. The third is purpose. That's clear. They have a clear purpose. The last is hope. And what I'm worried about is hope is draining from our healthcare providers after 2 years. And we need to give it back to them. We need to give them the tools to create safe cultures, and the leadership of our facilities need to do that, as Mike mentioned.
Great.
Thanks.
Thank you, Lee. Thank you, Lee. Thank you. Neelam, what about yourself? What do you think? What have you learned, and what should we have learned?
I think what I've learned is that patient safety was an afterthought, and the pandemic has shown us that there are major safety gaps across the health system, and which led to a serious avoidable harm in healthcare during the pandemic. So patient safety, which includes health worker safety and safe working environment, needs to be prioritized in the health agenda. And that should be hardwired. And that's what my most important learning is. because while we are addressing known risks, the new risks come up. So systems have to be very robust when we are developing it. And these three elements, as I said, patient, health workers, and environment, are very central to all efforts to rebuild health systems across the world. And when we are preparing up our plans for preparedness and response and recovery, dealing with health emergencies, patient safety has to be very much embedded in these. So we will have to have wide range of interventions need to be implemented based on the context and the prioritization in countries. But we need to have sustainable investment into this system and high level of political and institutional commitment. As Mike mentioned, we need leadership commitment and support to make it happen at all levels, at national level, subnational level, organizational level, facility level. We need leaders to prioritize action on patient safety, and particularly related to pandemic situation. Countries need to develop systems to identify all known and potential threats to safe functioning. And I don't think those systems exist currently.
Yeah.
Once we have identified all known risks, we have to develop the mitigation plans for those risks as well.
Right.
So I would say this is the time for us to prioritize and develop systems for safe and effective functioning of health systems.
Lovely. Okay. Thanks, Neelam. Thank you. I'll go to Mike next, and then Arjun. Mike, final message to give.
I want to compliment what Lee and Arjun are doing. They're putting online hospital complication rates. What are their actual CLABSI rates, their infection rates? What are their falls rates? And we need that information. That information needs to be transparent. It needs to be out there. Patients need to be able to see it. Hospital administrators need to be able to see it. This is how we're going to fix things with data. Yeah. And as they have the data and publicize it and put it online, we can all learn from it and correct it.
Okay, great. Thanks, Mike. Okay, Arjun, as the only man in uniform, you have to have the last. You have to have the last spell.
Well,
thank you.
Thank you. Thanks for this wonderful discussion. I think very quickly what I take from this and moving forward is we are all in this together, and we have to enhance our collaboration and partnerships. And I think those were there before, but I think what we have found during COVID is that we have been able to invigorate those collaborations in a way they never have before. As Lee mentioned, at the start of the pandemic, an hour a day, every day, CDC and CMS people coming together to figure out what can we do together. And the editorial is a reflection of the tightness of that collaboration. But it's not just the government, right? We need the professional organizations, the provider groups, the patients. All of us need to come together in a way that we never have before. And I think this pandemic is going to finally give us that impetus and that momentum to bring all of those groups together in a new way to make progress together.
Fantastic. Thank you, Arjun. Well, I know that our time is up. So may I just thank you all, Lee, Neelam, Arjun and Mike, thank you very much. It's been a thrilling panel. It's been a very fast-moving panel. It's gone very, very quickly. So I'd like to thank you all for contributing. I'd like to thank everybody for listening. And I think everyone who listens, I want you to comment on this program. I want you to comment on the panel and post comments about this. So thank you. There is this need for collaboration, a consistent approach to collaboration, because unless we can learn from each other and with each other, then we will continue to make the same mistakes that we've made for years and years. And our patients and our healthcare workers deserve better. So thank you very much for listening and looking. And I wish you a very happy and safe next few days and months and years. Thank you very much and goodbye.